Hello and welcome to this latest edition of our NRAS live series. I'm Peter Foxton, CEO of NRAS, and in today's episode we'll be talking about inflammatory arthritis and osteoporosis. Many of you will know that people with inflammatory arthritis are at a greater risk of developing osteoporosis, and maintaining healthy bones is an important part of managing your condition. I'm delighted that we're being joined this evening by Deborah Nelson, a clinical nurse specialist who works for the Royal Osteoporosis Society, who will be shortly sharing some slides about osteoporosis, how to manage it, and some of the things that we can all do to maintain healthy bones. After Deborah's talk of about 15 to 20 minutes, we'll be then running a question and answer session. We have some questions that were kindly shared by people when they registered, but if you have further questions, then please do add them in the comments and we will try and answer them or point you to where you might be able to find more information. So without further ado, I'm going to hand over to Deborah, who will introduce herself and take her through some slides. Thank you.
Great. Thank you very much indeed, Peter. It's lovely to be with everyone this evening. I hope that there will be some slides appearing, there we go, shortly. So I am an osteoporosis specialist nurse and I work with the Royal Osteoporosis Society. Just a little bit of why I could be and should be here with you tonight. I joined the Royal Osteoporosis Society in 2021 after many years working mainly as an osteoporosis nurse in HS Scotland, and as you might gather from the accent, I am speaking to you from somewhat north of the border. So the plan is that I'm going to have a bit of a talk about what happens to our bones as we become older, what osteoporosis is and why it matters, what are the risks that someone might have for developing osteoporosis and having an increased chance of breaking bones, and what connects rheumatoid or inflammatory arthritis and osteoporosis. How can we look after our bones using non-medication approaches, and sometimes medicines are necessary, and what those might be. And then, as Peter says, we'll come on to answering as many questions as we possibly can. Important thing to know is that bone is living, it's alive and constantly changing throughout our whole life. We make new bone and we lose bone. And you can see on this graph that early on in our life, we make more bone than we lose. And so our bones grow in size and strength until they become as big and as strong as they're going to be. And that's called peak bone mass and happens around about our late 20s, early 30s. And then things go fairly steady for a few years until around about age 40, we begin to lose bone strength related to the normal aging process. That continues then for lifelong, and the issue you can see is that as the older we become, the weaker our bones become, and because of that, the more prone we are to fractures. For women, there is an added issue that when in the years leading up to and following menopause, women have a time in their life where they lose more bone than normal. And so that, in combination with the fact that we often tend to have smaller, slightly weaker bones than men, explains why it's more women than men who get osteoporosis. And in fact, beyond the age of 50 until the end of our lives, around half of women, 1 in 2 women and 1 in 5 men will experience a broken bone related to osteoporosis. So although it's certainly more common among women, it's not rare among men. So thinking about what is osteoporosis, it is a condition where the bone becomes weaker and more fragile and more prone to fracture. And that happens because inside our bone, you can see on the left-hand picture here where there is lots of bone and smaller holes, and that's quite a strong structure which is not so prone to breaking. But when osteoporosis happens, those connections in the bone become thinner and some of them wear away altogether. And that you can see quite clearly that that structure on the right-hand side would certainly be more likely to break than the bone on the left, which is normal. Just want to clear up a little bit. I've talked about osteoporosis, and something that often causes a bit of confusion is people mix up osteoporosis and osteoarthritis. Although they might sound similar, osteoarthritis is about painful, swollen, inflamed joints, often related to wear and tear, where osteoporosis, as I say, is about the structure of the bone, how much bone there is, how strong it is, and in osteoporosis, where it is weaker and more prone to fractures and to breaking bones. And I'm using that term, fractures and broken bones. It means exactly the same thing. Some people who have osteoporosis can also have osteoarthritis. These conditions often happen as we all become older, so it's not uncommon for people to maybe have both. But understanding that if you have pain and stiffness, then that's more likely to be osteoarthritis rather than osteoporosis, because osteoporosis, when there have been no fractures, causes no pain or symptoms of any other kind. So if it doesn't cause symptoms, why does it matter? The fact is that if bones become weaker and more prone to fracture, then people have said to me when I worked in the hospital, what does it matter if I break a bone? I'll get a plaster on, I'll have an operation, it'll get fixed. But the issue is that if you break a bone, that means that you're more likely to break another bone. And the more bones you break, the higher that risk becomes. And fractures, although a broken wrist can be very painful and inconvenient, there are some fractures that affect the hip or affect the bones in the spine, causing people to become shorter and their back to become curved over. These kind of fractures, spinal fractures or hip fractures, can have a really big impact on people's quality of life and their ability to be independent. And so it's important to identify people who might have that higher chance of breaking bones so that we can do something about it. And one of the ways that we do that is looking at somebody's risk of breaking a bone. And one test for that is something that you might have heard of. It's called a DEXA scan, a bone density scan, where you lie on a couch. There's no need to go into tunnels or anything. It's a fairly quick test, uses low levels of X-ray, and we measure how much bone there is in two parts of the body, in the lower back and around the area of the hip. And the result of the DEXA scan is given as a T-score, and that tells us where you sit on that scale of bone strength. And where the T-score is a positive or a plus number, if you think of this like a thermometer, where if it's plus 10, it's warmer than if it's minus 10. So where it's a plus number down to -1, that's categorized as normal bone density. -1 down to -2.5 is called osteopenia, and -2.5 and going further down into the minus or negative numbers is osteoporosis. So we can use that information along with other information about other risks that are going to contribute to the chance of breaking bones, to think about what somebody's chance of breaking a bone might be. And there's a simple computer tool that can be used, taking some information about the individual, about their age and their body size, whether they're, their height and their weight, and whether they've broken bones before, and other risk factors that I'll talk about in a moment, to think about what that person's chance of breaking a bone in the next 10 years might be, and use that to think about whether that person might benefit from being on a medicine, or if a medicine is not necessary. So it's important that we look at the whole picture in terms of the risks for osteoporosis and broken bones, rather than just one simple part, one part of the risk. So of course, as you can see in the middle, low bone density, which is something we would understand from the DEXA scan, is important, but there are lots of other things. The ones that are in yellow I'm going to come back to in a moment, but I'm just going to cover the other things briefly. So we know that for many health conditions, too much alcohol isn't good for our health, and that's the same as for our bones. Many fractures, just working along the top of this little jigsaw puzzle, many fractures happen because of a fall. And so if somebody is prone to falls, if they've got poor balance, that can contribute to their chance of breaking bones. One of the things that helps strengthen our bones is when we're up on our feet and putting the weight of our body through our bones. That's called weight-bearing exercise, and I'll talk about that shortly. But having less weight to bear means that that effect on the bones and the activating bone building is reduced. So someone who's got low body weight for their height would be at a higher chance of breaking bones. And equally, if somebody is quite small and thin, if they fall over, they don't have much padding and cushioning, and so they might be more likely to fall and break a bone. Women who go through menopause under the age of 45, that means that their time in the remainder of their life without the protection of the estrogen hormone that protects our bones as younger women is longer, and so that can contribute. Talked about how as we get older, our chance of developing osteoporosis and fractures increases. And I've mentioned also that if somebody has broken a bone, they're at a higher risk of breaking more bones. Down in the bottom left, part of what increases our chance of having osteoporosis and broken bones is our genetics, our family history. And one that we don't go around getting gene tests all the time. We're not really at that stage at the moment in healthcare, but we can know if one of our parents broke their hip, that can be a sign that we might be at a higher chance of breaking a bone ourselves. And again, it will come as no surprise that smoking is not good for our bones, as it's not good for many other aspects of our health. So what specifically is it about rheumatoid or inflammatory arthritis that affects bone health, increasing the risk of osteoporosis and fractures? There's good evidence from research to say that there is something about that inflammatory process that releases chemicals into the body which are harmful to the bones, weakening the bones and increasing the chance of fractures. There are some medicines that are commonly used in inflammatory conditions to help dampen down that inflammation, and particularly steroids can be life-changing, can have a really miraculous impact on improving people's symptoms. But steroids also have baggage, and steroids can be very harmful for the bones, especially in high doses over longer periods of time. Steroids can mean that we make less new bone, lose more bone. It can lead the muscles to become weaker, meaning that we might be more prone to having falls. And it also means that our body gets rid of more calcium than usual. So for lots of different reasons, steroids are not good for the bones. Also, if somebody has got the rheumatoid arthritis or arthritis is not well controlled, that might affect their ability to be physically active. And we know that mobility and being active is good for helping to support bone health. So these combination of things can lead people who have inflammatory or rheumatoid arthritis to be at a higher chance of developing osteoporosis and fractures. So what are the things that we can all be doing to help look after our bones? I'm sure everybody knows that calcium is really important. And actually, the good news is that calcium is something that is found in lots and lots of different kinds of foods. And so although we automatically often think about milk and yogurt and cheese, actually green vegetables and fruit and nuts and so on can also be good sources of calcium. The general guidance is that we should try and eat and drink the nutrition that we need for our bones. But there's one exception to that. Vitamin D is a sunshine vitamin. And especially if you live north in the country like me, it's not really possible to get enough sunshine, to get vitamin D from the sunshine all year round. And so for some people, taking a vitamin D supplement can be a good idea. Exercise, I already mentioned, is really important for our general health, for our bone health, as well as our well-being. And being up on our feet and putting the weight of our body through our bones, with our feet bumping on the ground below us, that's having a level of impact as we move, is known to be good for the bones. The other kind of exercise is muscle resistance exercise, where the muscles are pulling against the bones. And we can use the weight of our own body, or use elasticated bands, exercise bands, or weights to do that. Important to say that if anyone is starting any new exercise, begin gently, build gradually, and take it slowly. And if something causes pain, stop doing it. The Royal Osteoporosis Society has got more information about exercises that are helpful for bones in our strong, steady and straight group of exercise information. And there'll be a link about that in the notes after this presentation. If somebody's got poor balance and poor muscle strength that might increase their chance of having a fall, we know that there are exercises that can be targeted to increase people's balance and reduce their chance of falls. Already talked about avoiding smoking and drinking too much alcohol, and the importance of keeping our body weight within the healthy range. So if medicines are needed, what kind of medicines are there? Because we know about what happens in the bones with bone being made and bone being lost, we can use that information to help target different kinds of medicine. The most commonly used medicines for osteoporosis are ones that reduce the amount of bone being lost. Some of you might be familiar with the bisphosphonate family of medicines, which would include medicines like alendronate or zoledronate. So alendronate's the weekly tablet, zoledronate is a once a year infusion or intravenous drip medicine. There's also a 6-monthly injection medicine, which works in a similar way. And for younger women, hormone replacement therapy, or HRT, can be useful and be considered. For some people who've got very low bone density, who've had multiple fractures and whose risk of further fractures is assessed to be very high, there are medicines that can be administered as daily injections, which increase the amount of bone that's being built. And that would be for a period of anywhere between 18 months and 2 years. And then it would be followed on with a medicine to decrease bone loss, like the zoledronate or denosumab, to lock in the gains made with those injection treatments and avoid you losing all that benefit and ending up back at square one. There is a medicine that does both increase bone building and decreasing bone loss, and that one is a monthly injection for 1 year called romosozumab. So the kind of people who might benefit from being on a medicine would be people where the fracture risk is assessed to be high. And most of these medicines are really aimed at people who are women who are postmenopausal or people who are over 50. For some people where the risk is very high in people under 50, medicines might be used, and in the sort of situation that might be considered would be where someone is needing long-term high-dose steroids, if someone is having multiple fractures or has got very low bone density, then the medication could be helpful in those situations. So the good news is that since I was a student nurse in the late 1980s in the rheumatoid arthritis ward, during my nurse training, arthritis treatment has greatly improved and control is generally possible to be much better with fewer flares. And that's really good because the evidence tells us that if rheumatoid arthritis and inflammatory arthritis is better controlled, that decrease in the inflammatory process reduction in the need for steroids, allows increased levels of physical activity, and all of those things are positive for bone health. And for people who do need medicine for osteoporosis, we've got a range of different medicines available that are typically very well tolerated and have been proven to significantly lower the chance of broken bones happening. On the Royal Osteoporosis Society website, we've got lots more information about bones and bone health, and you can find out more about that by Googling Royal Osteoporosis Society. And I understand there will be some links that we'll put on to Facebook at the end of the talk, and you can get more information that way. So I'd like to thank you very much for inviting me and for listening to me. And now I'll do my very best to try and answer the questions that have been submitted.
Thanks, Deborah. That was a really great talk and really clear as well, especially for somebody like me who doesn't have maybe the clinical or medical background. I found it really easy to understand. So thank you very much for that. I'll start asking some questions. The first ones I'm going to ask are ones that have been pre-submitted when people registered. But if you do have any other questions after listening to Deborah's talk, then please do add them in the comments and we'll come to those at the end. So the first question is from Liz, who has osteopenia, and she has rheumatoid arthritis and a bilateral Charcot foot, which she's had since January 2023. And her question is, how often should I have an MRI check my feet and ankle bones? I'm not sure whether that's one for you, Deborah, or do you have any knowledge on that one?
I think that might be better answered by you specialist nurses rather than me. That's more about the arthritis side of things rather than the osteoporosis side of things. Of course, there are some things that will still be helpful for Liz in terms of the kind of non-medication things, but I think probably that specific question better answered by your team.
Good. Okay. And I'll just share that if you have any questions, you can call our helpline that relate just to rheumatoid arthritis. You can call our helpline between 9:30 and 4:30 Monday to Friday, and the number for that is 0800 298 7650. So if anybody does have any general questions about rheumatoid arthritis or would like to find out where they can find out more information, then please do call the helpline and they'll be able to help you. Second question I have here is if rheumatoid arthritis is a known risk in osteoporosis, how frequently should someone with a diagnosis of osteopenia and RA have a DEXA scan? Okay, so really good question. And unfortunately, it would be lovely if we had universally accepted guidelines across the whole world to tell everybody, rheumatologists, this is what you should do for people's bones. Unfortunately, there aren't. Some rheumatology departments may have their own protocols and guidelines for this sort of thing, and some have none. For someone who has got rheumatoid arthritis, and if they've had a DEXA scan already showing osteopenia, often when the DEXA scan is done, there will be some recommendation about when follow-up might be recommended. You might remember from the scale of bone strength that I talked about, it was more like that, wasn't it? Up and down rather than across. So with normal at the top and osteoporosis at the bottom. If your osteopenia is right up at the normal end of osteopenia, then the need for a repeat DEXA scan is a lot less than if it's right down nearer the osteoporosis end of the scale. So it's kind of going to depend on where you were on that scale of bone strength to begin with. And if you have other risk factors, if you're over age 50 or age 60, how well your rheumatoid arthritis is controlled. But generally, if somebody has had a scan, it might be recommended to do another one somewhere between 3 and 5 years later. Generally, unless somebody's on high-dose steroids, changes in the bones happen very slowly.
And so if we do scans too close together, we can't measure any meaningful change and any difference between the results. And so it's better to leave more time. But of course, if a new risk factor occurs, a fracture, change in medication, health condition, then that might trigger an earlier bone density review. Do you think that answers the question?
That's a really great answer. Thanks,
Hopefully.
So we've got a couple of questions. One that relates more generally to RA, which I can pick up, but also one which relates to biphosphonates around dental health, and when should people with RA take bisphosphonates, and what is their effect on teeth?
Okay, so generally, if a bisphosphonate is necessary, that would be when someone has had a fracture risk assessment and it shows that their fracture risk, their risk of breaking a bone, is sufficiently increased that they will gain benefit from being on a medication. And so you need to have that fracture risk done, and that will guide who might need a medicine. And if that says yes, you would benefit from a medicine, the next question then is, well, which medicine? And in the UK, the guidelines, the NICE guidelines that tell us which people should get which medicines, generally say for many people, the first option treatment would be alendronate, which is the once a week tablet medicine. But for some people, if they have got maybe trouble with swallowing tablets, or if the tablets upset their stomach, then it can be given as an intravenous drip. That would be zoledronate. And for some people where those medicines don't suit, denosumab might be another alternative. And so it depends on fracture risk, and it depends on the individual person. So the next part of the question was about affecting teeth. It's not so much that the medicines like bisphosphonate, the ones that reduce bone loss, are affected with a condition called osteonecrosis of the jaw. It's not that it affects the teeth, it's that it affects the bone that the teeth sit in. And this condition is extremely rare. It's thought to affect somewhere between 1 in 1,000 and 1 in 10,000 people who are taking these osteoporosis medicines for osteoporosis. These medicines are also sometimes used for people who have cancer, and in that situation they would be used in much higher doses, maybe 10 times as much as we would use in osteoporosis. So in that situation, the risk of osteonecrosis of the jaw is much higher. But for people having the medicines for osteoporosis, the risk is very low. Useful to understand that if anyone is on steroids, that can slightly increase the chance of osteonecrosis of the jaw. But these are things that you would discuss with your rheumatologist and with your dentist to get guidance on that. Generally, though, the guidance from dental experts is that the most likely thing to happen is a fracture. The least likely thing to happen is osteonecrosis of the jaw. So if you've got osteoporosis and you need a medicine, you should have the medicine. But make sure your dentist knows what you're on. And if they can avoid taking teeth out, which is the procedure that might set this complication off, then it's better to avoid having teeth out. But if you need a tooth out, it can be taken out, but it just you need to keep an eye on the mouth, make sure it's healing normally. And if there's a delay in healing, that should trigger a referral on to a dental specialist for assessment to get it treated.
Thanks, Deborah. That's really comprehensive. Thank you.
That's one of the most complicated topics that we have to deal with, but it's something many people worry about, but really I want to be very clear that it is really a very, very rare thing, and it's really unlikely to be a problem.
Thanks. And just generally on teeth, there was another question around RA having a negative effect on teeth, and yeah, there is some evidence to that effect, and we actually did an NRAS live on oral health last year, which you can still find on our website or on the YouTube channel. But I think one thing just to kind of remind people, and this was really the focus of the talk, was that maintaining good dental hygiene, going for routine dental checks, and reporting any oral symptoms that occur is really the most important thing, and the best thing that you can do to protect your teeth. So,
Absolutely, and that same goes for people with osteoporosis.
Yeah, good. So the next question is: are there any exercises that are specifically proven to help those suffering with osteoporosis? I know you touched on this in your in your talk. I don't know if you just want to remind people of those.
I think there's lots of different things, and the thing that I usually say is find something you really enjoy doing, because you're going to have to do this for the rest of your life. You're not training for the next Olympics, you're training till you're 80 or 90 or 100. So you've got to like what you're doing. And the things then, that finding activities that you like doing, that maybe if you like being amongst people, exercise classes, and there are classes for people who maybe have health conditions that might be adapted for, to avoid injury, that you find out about those in your local leisure centre. But specifically the kind of movements that are helpful for the bones are weight bearing, so up on your feet, putting the weight of your body through your bones. So swimming is a lovely exercise, but you're supported in the water, so that's not going to be especially good for the bones. Wouldn't discourage you from swimming if you love it, but also do other things. Same with cycling, you're sitting on your bottom, you're not up on your feet. So these exercises have benefit, but not specifically for the bones. So things like dancing, aerobics, walking, jogging, but you don't have to be doing leaping around. There are, for people who are a bit less able, there are a series of exercises that you can do in your own home, and we definitely have some links. One of the links that is going to go into the chat with the talk is the link to building up exercises for bone strength and how to exercise safely. And those films guide you through recognising that exercise, the benefit greatly outweighs any risk. The chances of you causing a fracture with exercise are really small, so don't be afraid. And talking about those exercises, weight bearing with impact and starting off gently, building gradually over time, also including exercises where your muscles are pulling against the bone, using some resistance, and that can be either using the weight of your own body to work against, using elasticated exercise bands, or even weights. And it's a case of finding what's right for you, what's going to fit in with your physical ability, and something that you enjoy doing and can stick with in the long term.
Brilliant. I think, yeah, exercise in general, that manageable exercise is always a good idea. And there's some more information on the NRAS website, and particularly there's a Smile module about exercise and movement in our online e-learning platform, which is really useful. And accompanying that, there are a few short videos that I saw in the chat that Lindsay had mentioned, Tai Chi, yeah, there's a little taster video on Tai Chi with some exercises. So do have a look at those resources, and there's lots of other resources on the internet as well, which you probably find useful.
Just to mention, certainly Tai Chi, yoga, Pilates, these are nice exercises because they can be quite social. They're also quite nice for building up muscle tone and improving balance. And if your balance is better, you're less likely to fall, less likely to fracture. But they're not, it's important to remember to incorporate that other impact exercise as well, and do the whole package rather than only just one type.
Mm-hmm. Definitely. Okay, so there's some questions around nutrition and supplements. The first one is, are there any foods that we should avoid while living with osteoporosis and RA?
Okay, so the good news is there's no such thing as a bad food. So even the things that are some things that we should eat lots of, green vegetables, and there are some things that we should eat a bit less of, cakes and biscuits. But things in moderation. Having a healthy, bone-friendly diet is not any different from what is recommended for everybody, and that is focusing on fresh fruit, fresh vegetables, a good amount of healthy protein, so things, if people eat meat, then fish and chicken and other meats. If people are vegetarian or vegan, then nuts and pulses, beans and lentils and so on can be a good source of protein, as well as being a good source of calcium. Dairy produce, if people enjoy having milk and yogurt, useful to understand that skimmed and semi-skimmed milk actually contains slightly more calcium than full cream milk. So where there doesn't need to be a conflict between thinking about our cholesterol and heart health and making sure we're getting enough calcium for our bones. For people who don't want to have, would prefer to be dairy free, there are now a whole range of non-dairy milk drinks, and many of them are actually fortified with calcium. So if you're going to have an oat milk or a soya milk or something, if you can find one which is fortified with calcium. They tend to have a similar amount, round about 100 milligrams of calcium per 100 millilitres of the milk, which is very similar to dairy milk. And even, things like alcohol, so long as we all stick within the government guidelines, no more than 14 units of alcohol a week, and making sure that we have a few days that are completely free of alcohol in the week, then it's fine to have a drink. But it's just when we have more than that. Again, nutrition is something that people have lots of questions about, and there will be a link to get more detailed information about that from our website. In general, osteoporosis specialists would now say that where we can eat and drink the nutrition that we need for our bones, there's much more nutritional value in real food than taking supplements. So if you think having a glass of milk would give you 200 milligrams of calcium, but it also gives you protein, and there will be other nutrients in there that are important for our health. Whereas a calcium supplement, it's calcium full stop. And so if we can eat and drink what we need, that's ideal. And where we can't get it all from our diet, then supplementing, topping up with a supplement can be helpful.
Thank you. That does relate. There's a few questions in the chat about supplements. There's one about dosage of vitamin D is recommended, and is vitamin D3 and K2 best? Okay. I guess that would depend upon the person as much as anything. Yeah.
So for the general public, if they're going to take a vitamin D supplement, the suggestion is that should be 400 international units of vitamin D, and sometimes that's written as 10 micrograms, which is like a little backwards U and a G. For people who have osteoporosis, often we would recommend between 20 and 25 micrograms of vitamin D, which is the same as 800 to 1,000 international units. And that is partly because when the studies were done looking at the osteoporosis medicines to see if they worked, the studies included people taking supplements to that level. And so we know that that's what's helpful. There are some people who are maybe indoors all the time, so that are housebound, people who have dark skin colour, or who cover up for cultural or religious reasons, who may actually need higher doses than that. And that would be something that would be guided by their own doctor. But for the general population, 400 international units for someone with osteoporosis or who's on osteoporosis medications, 800 to 1,000 international units. Vitamin K is something there's a lot of talk about, and we hear often about vitamin K because that helps calcium get to the bones and so on. There is some evidence to say that vitamin K is probably helpful for our bones, but what we don't have is any good research evidence to say that taking a supplement is necessary. So what the government guidelines say is if you want to take a vitamin K supplement, provided there's not a reason not to do that, and perhaps people who are on medicines to thin the blood, anticoagulants, should check with their doctor before they take vitamin K. But for many people, if they want to take it, the guidance would be that so long as you don't take more than 1 milligram of vitamin K per day, it's not likely to do any harm. So we don't know if it does any good, but at that level, it's unlikely to be harmful.
Good. And then I got two questions which are in the chat about collagen, and one of those also includes creatine as well. So whether they should be avoided with medications, it seems to be the main question, or whether they should be avoided altogether.
So generally, the kind of guidance is eat what you need. The issue is that there are some companies who are trying to sell a product, and their product is made out, their advertising appears like medical information. And some of the collagen supplements, some of the advertising around that looks like that. Generally, when we've spoken to nutrition experts about this, people who take collagen supplements, it tends to get digested in the stomach. And so it's really not, there's no evidence to say that that would be particularly beneficial for our bones. And I know that these things are, they're widely advertised, and people are really keen to do everything that they can to help support their bones. But there's no good evidence to say that taking these supplements is of proven benefit. And they're very expensive often.
Yeah. Okay, that's good advice, thank you. And then I think we covered most of the questions. There's a couple more questions. Just checking there's anything we haven't already covered. If people have concerns or questions around taking their medications, what's the best thing to do? Is that to go back to their personal, to their doctor and discuss it with their consultant? So
there's a couple of things that we can think about. Sometimes people are worried about trying a medicine because they're worried that they might get a side effect. And we don't, it's then you're not doing something which potentially could be beneficial because of something that might or might never happen. There are none of the osteoporosis medicines that if you start them, you must stay on them. All of the osteoporosis medicines, if you try it and it doesn't suit you, it can be stopped and changed. So don't be put off trying something. If you do try something, and if it's a tablet, if it upsets your stomach or causes aches and pains in the muscles or bones, then maybe that's not the right medicine for you. And don't try and stick with something that's not suiting you. In that situation, going back to the person who prescribed the medicine to think about whether there's an alternative that might suit you better. Because there's a whole range of different medicines available, and we can usually find something to suit most people. Our helpline in the Royal Osteoporosis Society, our nurse helpline, about 60% of the calls we get relate to people's questions about their medicines. And because of this, we have developed and just last week launched a program called Bone Med Online. It's a free digital program. You can see information about it on the front page of the Royal Osteoporosis Society website, and I think we'll put a link to Bone Med Online in the chat. It's a one-year program. You sign up to it. It asks some questions about what medicine you've been prescribed, what your thoughts and concerns might be about taking that medicine, and then provides for the coming year at intervals, not constant bombarding, but over intervals in that year, provides information and support, practical information to help people get into the good habit of taking their medicine, information in terms of support to help reassure people about the benefits of having the medicine and what to do if they get side effects. And so that is something, either phoning the helpline to speak to one of the specialist nurses or signing up for Bone Med online. And as I say, it's a free programme. You can opt in or opt out at any point. There's no obligation. But we're hoping that people are going to find this really useful, because medicines is something that a lot of people have questions and concerns about often.
Yeah, and then I know our helpline would probably say the same in terms of
I
the
can
volume of
imagine.
calls about
Yeah.
medicines, and
Yeah.
and I think that both organisations, the helplines are really great. It's manned by trained people, especially trained people who can give good advice or signpost you to where you can find the information you want. So do use the helplines. I know we had one question from somebody who'd been recently diagnosed with RA, and again, my advice would be to use that helpline to get that early information, and hopefully we can help you to start self-managing your condition. So it sounds like at the moment you're struggling. So if that person is on the call, then please do call the helpline tomorrow, and we'll try and give you some help. I had another question really, which kind of relates to that, which is we're really proud of our peer-to-peer support networks, and particularly around groups and support groups, volunteer-led support groups that we do virtually, but also meet locally. Is there anything like that for people with osteoporosis?
Yeah, certainly is. And again, there's more information about that through the website. We do around the country have, not in every single location, but there are physical support groups where people meet in person. There are some of the support groups which do virtual support groups, so you can join if there's a topic you're interested in. You can join from anywhere in the country. Free, you just click on and then sign up to get the link to be able to join that particular support group meeting. We also have a Health Unlocked peer-to-peer osteoporosis support group, which again, the online community is something that you can find links to from the Royal Osteoporosis Society website. And you're absolutely right, Peter, that notion of speaking to other people and being able to interact with people who have been through or going through the same sort of thing that you are can be really invaluable for people. And I just want to mention one other thing that we have just recently set up. Osteoporosis is much more common in women, but 1 in 5 men in later life can be affected too. And often even doctors can think of osteoporosis as a little old lady disease. And men can feel really quite isolated and a bit odd about having this old lady disease. It's really important to recognise that's not the only group in the population who get this. And we actually do have a section on our website that is specifically targeted with information for men, and and able to get some more male support in that way.
Oh, that's really good to know. That's a really good initiative, I think, as well. Okay, so I'm just looking through. I can't see any more questions in the chat. There's lots of very positive comments about your talk, Deborah. So thank you. And hopefully people can see the links in there as well. I hope that everybody has found the session useful. I personally feel like I've learned a lot tonight about what I need to do to keep my bones healthy, and I'll definitely be exploring more about exercise and nutrition. There's also, as we've said throughout, that there's more information available both on the NRAS website and the Royal Osteoporosis Society website. So please do check those out. If there's anything else you'd like to add before I finally wrap up, Deborah?
No, I don't think so. Just thank you very much indeed for having us along. It's always lovely to meet other groups and to share the messages about happy bones and bone health. And so thank you for having us. And if there's anyone has questions or anything they would particularly like to talk to an osteoporosis specialist nurse about, our helpline telephone number can go into the chat as well. And again, we're open Monday to Friday, 9 till 5, with a bit of a stop off for a meeting and a bite of lunch between 12:30 and 1:30. Our helpline does get very busy. So sometimes midweek can be a bit better time to try and get through. If you don't get through, persevere, and you will find one of us in the end.
Thanks, Deborah. We're also really grateful for you for joining us this evening, and it's been great working with the Royal Osteoporosis Society on this little talk. And also, I just like to mention at the end that both organisations are charities, and we do rely upon public support for funding. So we're always grateful for anyone who can support us in any way. And we'll be sharing some links to the membership pages for both organisations. Being a member is a really great way of supporting, but also getting the most up-to-date information about both of the conditions, and also kind of great stuff on research that's happening, advice on nutrition and exercise and all those great things. So please do have a look at that if that's something that appeals to you. And thanks everyone again for joining. Just there was one question in the chat. Yes, this session has been recorded, so it will be appearing pretty much straight away on our YouTube channel, and you can also access it from the website. So please do go back and have a look if you want to listen to some of the information again in more detail, or please tell other people about it so they can come and have a look as well. And that kind of wraps us up for this evening. So thank you everyone who's joined, and thanks again to Deborah, and I hope you've found this session useful.
Thank you. Bye.